Warm greetings to you all. Today we'll be discussing about acute disc prolapse. When we talk about prolapsed discs or disc slip, then actually it is not that the intervertebral disc has slipped from the vertebra itself. Actually, what happens is that the part of the inner softer part of the disc, that is the nucleus pulposus, bulges out and herniates through a weakness in the outer part of the disc. That is, that the nucleus pulposus it bulges out from the nucleus annulus fibrosus. So a prolapsed disc is sometimes called a herniated disc. Now let's revise the normal anatomy of the intervertebral disc. So we see here, this is intervertebral disc. Intervertebral disc comprises of two parts, that is nucleus pulposus and annulus fibrosus. So nucleus pulposus is the central jelly-like substance here, and annulus fibrosus are this fibrous band. When you see the horizontal section, the nucleus pulposus lies at the center towards posterior aspect. However, the annulus fibrosus they encircle in a spiral way around the nucleus pulposus. So normally the nucleus pulposus it is rich in proteoglycan, and because of that rich proteoglycan content it is hydrated, and because of hydrated it maintains the jelly like consistency. And now you see, when there is axial force or the vertical loading force applied from above to down, then this jelly like property or the jelly like consistency, because of this it distributes the vertical force centrifugally, and because of the centrifugal distribution of the force it transmits the force towards the annulus fibrosus. Now you see the annulus fibrosus they are spirally arranged, and because of the spiral arrangement of this annulus fibrosus they tend to cancel the horizontal force acting, and because of this the two forces going towards opposite direction they cancel each other, and because of this phenomenon the intervertebral discs act as a shock absorber. So this is the normal anatomy and the normal biomechanics. However, when during the degeneration process the hydration of the nucleus pulposus is decreased and reduced, and because of this different dysfunctional changes takes place, such as there can be tear, there can be fissures in the annulus fibrosis. So this is the annulus fibrosis, and these tears they tearing or fissures they coalesce and form a tract, and through this tract the content of the nucleus pulposus bulges out, and this bulging out of the content of the nucleus pulposus is known as prolapsed disc. So you see here the disc has been prolapsed. In this figure here there is prolapse of the disc. Pathophysiology of disc prolapse. Disc herniation is one of the early stages of lumbar degeneration. In Kirkcaldy-Willis hypothesis, we have learned that disc herniation takes place in the early dysfunctional stage. Internal disc disruption causes microscopic radial and annular tears within the annulus fibrosis. So as I have already told you, different microscopic radial and annular tears takes place in the annulus fibrosis. And these tears eventually coalesce, resulting a weak tract. So there will be the formation of tract. And the nucleus pulposus herniates through this potential tract under sufficient pressure. So you see here, with aging, vascular channels start to fail and vascular diffusion of the nutrients decrease. So you see these are the vertebral end plates. Actually from these vertebral end plates diffusion of the nutrition into the nucleus pulposus takes place. But what happens during aging? During aging these vascular changes they fail. There will be sclerosis of in plates because of the smoking. There can be reduce in the vascularity of in plates because of the atherosclerosis or because of the sickle cell anemia or any other cause which leads to decreased vascularity in the in plate. And especially in aging, this process is rampant, and because of that the diffusion of the nutrients to the nucleus pulposus is deficient. So the synthesis rate and concentration rate of proteoglycans is decreased. You see here, now the content of the proteoglycans in the nucleus pulposus is decreased. So what are proteoglycans? Proteoglycans are negatively charged and they are hydrophilic. So they tend to attract water. So when the content of the proteoglycans decreases, water binding capacity of the nucleus also decreases. Now what happens? The nucleus is dehydrated. Because of that, it becomes more fibrous and stiffer. Now the nucleus is less able to bear and disperse the load. So the normal biomechanics, now it has been hampered. So when there is disturbance in the normal biomechanics, suppose if there is annulus intact, for time being we say that the annulus is intact, then what happens? So this is anterior segment of the spine and this is posterior segment of the spine. We know that the 70% of the load is transmitted from the anterior segment and 30% from the posterior segment. So what happens during when there is abnormal biomechanics, then what happens? The force is transmitted from anterior segment to the posterior segment, and because of this the facet joints share even more of the axial load, and then the facet joints undergo degenerative changes and osteophytes they get developed, and because of that pain is seen, and as a whole this all together is known as facet joint syndrome. Now another thing, let's say that the annulus fails. So during aging process and because of the constant mechanical force, there are certain radial tears or fissures in the annulus pulposus. And when these fissures they coalesce, they form a tract. And through this tract, what happens is that the content of the nucleus pulposus they are released. So you see here, the fissures develop across the annular lamellae and may extend up to the disc periphery. Internal disc disruption cause axial pain. So you see, because of the disc disruption, because of the chemical mediators like prostaglandin E2, prostaglandin F2 alpha, nitric oxide, they cause irritation to the nerves. And because of this, axial pain is seen. And there is expression of this degraded nuclear material through these radial fissures, and because of this expression there is bulging through the fissures or the nucleus pulposus, and it gives rise to disc prolapse. So this is the pathophysiology behind the disc prolapse. Now we can classify intervertebral disc prolapse based on the direction of herniation. It can be anterior, it can be posterior, it can be lateral or intravertebral. So you see here, it can be anterior, posterior or lateral. Most commonly posterior is the most common seen. And there is Whistler classification which classifies the posterior dislocations into different zones and different levels. Let us first discuss about the zone. So basically there are 4 zones. So what are these? These are central, paracentral, foraminal and extraforaminal. Now you see here, this centermost area here, this one, this is the central zone. And you see here, from external layer of the dura to this pedicle area, so this much area is the paracentral or posterolateral zone, and this area is the foraminal zone, so between the pedicles, you see here, and beyond this or lateral to these are the extra foraminal. So in this section you see here, so when there is disc prolapse from this region, it is central. So as close to the canal or the spinal cord, it is central. Whereas a little bit lateral, but it is medial to the pedicle. So this region is subarticular or posterolateral or paracentral. And when it arises from this area, it is foraminal, and beyond the foramen or the pedicles is the extraforaminal, lateralmost. So which type of zonal defect is more common? Can you guess? The most common one is the posterolateral. Why is it most common? Because the posterior longitudinal ligament is weakest at this portion. So the posterolateral disc prolapse is more common. So what are the clinical implications behind this? So you see here, when there is disc herniation in the central zone, so what we have discussed is that central zone was close in vicinity to the spinal cord. So this is your spinal cord, and do you recognize this structure? This neurovascular bundle, they are cauda equine. And this cauda equina, when there is central disc prolapse, suppose disc prolapse in this region, then what happens? The cauda equina, they gets compressed, and because of this there is high tendency of cauda equina syndrome. Another implication is that when there is posterolateral herniation, it would primarily affect the traversing nerve root. So we will discuss this in later part. And when there is foraminal or far lateral disc prolapse, it would impinge on the exiting nerve root. So now here two things we have been come across, that is transverse nerve root and exiting nerve root. We will discuss this through this diagram. So you see here, in this diagram, so you see here this level. This level is intervertebral disc level of L4, L5. So this is L4 and L5. So between this L4, L5 intervertebral disc level, your L4 lumbar, so L4 lumbar nerve is exiting. So this is your exiting nerve. So this L4 nerve root is your exiting nerve. However, you see here L5. So L5, though it is being exiting from here, but its origin, it takes place a bit high here. So what happens is that, suppose there is, so in case of central disc prolapse, so this is your area where central disc prolapse takes place. So in central disc prolapse, there is high chance that the cauda equina, it may get impinged and it can give rise to cauda equina syndrome. But suppose this is posterolateral segment, suppose here it has now disc has been prolapsed in this segment, then what happened, as we have already discussed here, when there is posterolateral herniation, so you see here, when there is posterolateral herniation, it affects the traversing nerve root, isn't it? So you see here, so when there is posterolateral herniation in this region, it is affecting the traversing nerve root. So which one is the traversing nerve root here? This one. This is the L5. So the L5, though it is exiting from this level between L5 and S1, but its impingement is seen when paracentral disc prolapse is seen at the level of L4 and L5. So this is L4 and L5. When there is subarticular or paracentral disc prolapse, then the traversing nerve root is impinged. However, when there is foraminal or extraforaminal, suppose this is the region where foraminal or this is the region where extraforaminal disc prolapse takes place. So this time when there is foraminal or extraforaminal disc prolapse, it is affecting the exiting nerve root, not the traversing nerve root. So the L4 nerve has been impinged. So this thing you need to keep in mind. So you see here, when foraminal or far lateral disc prolapse takes place, then the exiting nerve root is impinged. However, if it is posterolateral herniation, then traversing nerve root is impinged. Suppose let's say here, this is intervertebral disc level L4 and L5. Suppose this is herniation took place, suppose here this level. If in this level if there was herniation, then so this is your exiting nerve root, but you see paracentral disc herniation will hamper which nerve? Traversing nerve. So somewhere here there goes your L5 nerve. So when there is disc herniation, that is paracentral disc herniation, then L4 will be mostly affected. But when there is foraminal or extraforaminal disc herniation, then L4 is affected. So this concept you need to keep in mind. Now another clinical application is that for peripheral herniations, especially posterolateral herniations, the disc material may present beneath the nerve root or above. So what happens is that, so you see in this figure, here is the disc herniation. However, the nerve root, it is lying medially, isn't it? But in this case, primarily so in this case disc herniation has taken place here, and the nerve root, it is lying laterally. So when the nerve root lies laterally, it is called axillary lesion, and when the nerve root lies medially, it is called shoulder lesion. So what clinical implications does it have is that when the nerve root lies medially, because of the proximity of the herniation and the nerve root, there will be irritation, isn't it? So to prevent from that irritation, what person tries is that they tend to tilt in one direction where there will be no irritation. So when there is herniation here and nerve is here, so in which direction will he be tilting? So he will be tilting in this direction, because when we will be tilting in this direction, there will be no contact. But however, if the person was tilting in this direction, then this nerve root would have been come in contact with this prolapsed disc, and because of that irritation, and then it will potentiate to pain. So this thing you need to keep in mind. In shoulder type of lesion, the nerve root lies medially to the prolapsed disc, and people tend to suppose, if there is left, suppose this is a left side, if there is left side disc herniation, then they tend to shift towards right side. But in case of axillary, you see here there is herniation of discs and there is your knob root. So you see here the person he has been shifting towards this side so that the knob root is not in contact with the herniation part. But if he would have tilted to this side, then what happens? This knob comes in contact to this herniated disc, and because of this irritation, the patient will complain of pain. So this thing you need to keep in mind. So we have already talked about this. When there is central disc herniation, there can be central compression, cauda equina syndrome, or here also it can be. But if it is paracentral, then traversing knob root. But if it is foraminal and extraforaminal, then exiting knob root. This thing needs to be kept in mind. Another, we have already discussed about zones, and another classification is on the basis of level. It can be suprapedicle, pedicle level, infrapedicle, and disc level. So you see here, so these are nothing but pedicles. So if herniation takes place in this region, then it is pedicle level. If it is above the pedicle, it is suprapedicle level. If it is below, then infrapedicle. If the herniation takes place between the level of the intervertebral disc, then it is disc level, like this. So if herniation was only up to this level, then it is disc level herniation. Now on the basis of morphology, the intervertebral disc prolapse can be divided into balls, extrusion, protrusion, and sequestration. So balls means nothing but it has come out of the area of the vertebral body. Suppose this inner one is your vertebral body portion, this inner one, isn't it? So disc was also lying. So you see here. So this region is your vertebral body. So I am showing you your horizontal cord section. So this is your vertebral body, isn't it? Sorry. So this is your vertebral body circumference. And above this vertebral body lies your what? Lies your intervertebral disc. So actually the intervertebral disc is confined to this level only. But what happens in balls? So this is your, sorry, this is your intervertebral disc. But what happens in balls? In balls, what happens is that you come out of the level of the vertebral body. So you see, this outer circumference is the bulged intervertebral disc now. So this bulging can be symmetric and it can be diffuse, meaning as a whole. You see here, it is diffuse and symmetrical. Sometimes it can be asymmetric. So you see, certain degree of bulging is here outside the level of vertebral body. You see here, this much has been bulged. So this is nothing but bulging. Another is extrusion. So in what case do we call it as an extrusion? So extrusion, you see here, this is the extrusion part. So how do you define it? So when the base, you see, look at the base, and when the base transverse diameter is greater than the AP diameter, then it is extrusion. So the base is broader, basically what I mean to say is that. And now you see there is something called protrusion. So what is protrusion? In protrusion, your base diameter is very less. So it is sometimes referred as pedunculated type. So it is non-pedunculated, your base is more, you see here how much more it is. So this is your extrusion type. But when you see find as a pedunculated type, then it is your protrusion. Now when the herniated or the prolapsed disc part, they get dislodged, you see here it has been dislodged and it is not in continuity to the nucleus pulposus, then it is known as sequestration. Another term is content versus non-content. As we have already discussed, this is your nucleus pulposus. Around nucleus pulposus, what it was there? It was annulus fibrosus. Suppose this is your outermost annulus fibrosus. Now let's say there is certain bulging. So you see here. So the content of the nucleus pulposus, it has been prolapsed. But you see here the outermost boundary is this outer layer of the annulus fibrosus. So when there is still outermost layer is containing the content of the bulge material of the nucleus pulposus, then it is content type. However, suppose if this prolapsed disc transverses all the layers of the annulus fibrosus, then this is known as non-content. Now it is not contained within the annulus fibrosus. So this is non-content variety now. So you see here, this is simply bulge type variety here. And you see here, there is disc prolap. However, the outermost annulus fibrous has been protecting it. So it is content type. Here you can see this is most likely because of the ligamental capsule. And you see here no protection at all. So it is non-content type. And you see here, this is perfect example of sequestration. So let me erase it and show you again. So this is perfect example of sequestration because there is discontinuity. So what is the clinical implications of content versus non-content is that when it is non-content, so suppose this is non-content one, it is lying freely in this area. And when it is not content, then it comes in action of proteolytic enzymes. And because of this, they are resolved faster. So the non-content variety, they have better prognosis or they resolve spontaneously. Now signs and symptoms. A number of patients are asymptomatic. Suppose you do a screening MRI in a general population, then you may find different level of disc degeneration, different level of disc prolapse. Patient, they may not have any symptom. However, the most common symptom being the pain. So there can be preceding level of long-standing back pain and acute pain episode followed by a fall, twisting, or a heavy weight lifting. And the pain, it can be axial back pain, and there can be radicular pain when radicular knobs they are involved, and it can be sharp shooting type, dull aching, burning, sciatica like features. Now, in this radiculopathy, we need to learn about dermatome and myotome. So the all the pain, motor and sensory disturbances that we find, they take place at the level of dermatomes and myotomes. So you see here, this is your L1 level. Similarly, this is your L2 level, L3 anterior mid thigh level, lower thigh, L4 medial seam level, lateral aspect of the leg, L5, S1 outer aspect of the sole, inner sole, and you see here outer thigh and middle of the leg. So L5 you can see here also, and S1, S2, S3, S4 and S5. So you can see here. So in this way, you need to memorize your dermatome and myotome, and on the basis of this, you can have clinical correlation. So you see here, suppose if there is pain, and S1 is the predominant knob that is being involved, then pain at the back of the thigh, calf or lateral aspect, and sole of the foot. So similarly, L5, L4, L3, and L2 and L1 you can study. And another is when there is nerve compression, it can give rise to sensory and motor defects. So sensory, same at the level of dermatome, motor at the level of myotome. And disturbance is in gait like slapping gait, there can be foot drop, there can be high steppage gait, Trendelenburg gait when there is L5 defect, and sensory numbness, paresthesia, bowel and bladder incontinence, and saddle anesthesia. Then we need to suspect cauda equina syndrome, and there can be sometime ankle or reflexia, then high suspicion for cauda equine syndrome. And trunk tilting, as we have already discussed in case of axillary versus soldier type. So what happens in axillary type? So you see here, so this was the example of axillary type here. So you see herniated disc is here and the nerve root is going in this way. So to compensate, to be free from the pain, what he does is that he leans towards this side so that the nerve is away from the herniated disc. If he had tilted in this side, then what happens? This nerve would come in contact with the herniated disc, and because of this, there will be irritation and pain. So this correlation you can find, and different tests you can do: SLR test, straight leg raise test, femoral stress test, and you can look for muscle atrophy, of course, and you can see oriflexia, especially ankle. And on the basis of myotome, you can see different motor action. Suppose L2, flexion of the hip is predominantly done by L2, knee extension by L3, foot dorsiflexion by L4, big toe dorsiflexion by L5, and foot plantar flexion by S1. So on imaging, so because of disc prolapse, what happens? Your paraspinal muscles they go into spasm, and because of that, there will be sometimes loss of lumbar lordosis in the X-ray. And osteophytes, disc space narrowing, sclerosis of vertebral plates, these all features can be found in degeneration of the disc. And since degenerative changes precedes the disc prolapse, so these features can be seen. MRI is the gold standard, and when MRI is contraindicated, you can go for CT myelogram. So this is MRI image. So you see here, so measure the intervertebral disc height. So when you come from above to down, usually the intervertebral discs they tend to grow, but you see here it is wider, here it is slightly reduced, here it is okay, decreased, and you can see here there is bulging of the intervertebral discs, and you can see here the homogeneity of the nucleus pulposus is lacking. It is unclear, so this additional information also you can get here. So you see here there is disc herniation, so you compare the height, slightly decrease, more decrease here also, but here disc herniation has taken place. Treatment. uh, Usually what happens is that disc prolapse, they tend to be uh, like resolved when managed non-surgically. So surgical intervention need not to be done. So 80 to 90% of the patient will obtain symptomatic relief within 2 months. So you see here this is one MRI of a person. So you see at the level of L4 and L5 there is disc herniation. But when the patient was followed up after 5 months, you see here the disc herniation, it has resolved between L4 and L5. So most of the patient, they tend to resolve, especially within 6 weeks, and you see here up to 80 to 90% within 2 months. But about 10% of the patients do not get satisfactory pain relief or may develop recurrent pain or develop a significant neurological deficit that necessitates surgery, such as Cauda-Equina syndrome may precipitate. In these cases, we need to go for surgery. Otherwise, they need tend to uh, have good prognosis by by only pharmacological or non-surgical intervention. One interesting fact which I would like to share is that we discussed about extrusion and sequestration. Sequestration means loss of continuity. Extrusion means uh, that it is pedunculated type. Protrusion means base it is broaded. So you see extrusion and sequestration, they tend to have better prognosis than the protrusion, and you see that the larger fragments have better prognosis than the small fragments. So this is interesting fact you can see here. Now the non-operative treatment. So rest, usually the rest is advised for acute phase 2 to 3 days rest, and then gradual day-to-day activity. Slowly we can move on. Another is heat therapy, pain medications, ladder pattern you can go, and back strengthening exercises, education and counseling especially done about the posture and body lifting, weightlifting, different things. And another things you can see here is non-surgical minimal invasive treatment. The first pain, pain, it is chemonucleolysis. So what it does is that it so the injection is put into the nucleus pulposus, and the content of the nucleus pulposus is decreased, and because of that there will not be much tension, and it acts as such a way that the content is less in amount and the displacement force is slowly decreased. In laser technique, again we act at the intervertebral disc level. The main theme is that to decrease the content inside the intervertebral disc. So radio frequency ablation and automated percutaneous discectomy, like suctioning type of thing it is. And another is ozone oxygen therapy, which also aims at reducing the content. Surgical treatment, when to be done? Suppose you have followed for 6 weeks, the pain of the patient does not subside, it aggravates more and more, then we go for surgery. Suppose there is features like Cauda-Equina syndrome, then we go for surgery. And the pain, it tends to increase and increase, then we go for surgery. So what are the different modalities? These are the different modalities which you can see here. So this much for today. Thank you. Have a wonderful time.